So I decided to make you smile with my first two slides. A few people were asking me, how do you get the rehab going, dogs? And this owner trained the dog to do gastrocnemius stretching exercises, active exercises. So the rehab success depends on the owner. There are some owners that are incredibly compliant, and also on the dog. Because, I mean, a border collie, it's an incredible breed. I think one of you guys have it. Anyway, so this is a funny one. This is a real tough patient. You cannot mess it up. So this is a shoulder arthroscopy for a septic arthritis in a tiger. I did a few of those. So I decided to add a few slides before I get into prevention strategies. After listening to Alan, it was very intriguing what you are proposing to do, and I want to show you what we're actually doing for pure survival, because we don't have space. Shoulder relaxation in a cat, and you can see behind the subscapularis tendon is ruptured. I'm entering with a tiny but huge bone anchor, and I'm bracing. And I would say I'm bracing the joint. So anteromedial portal, you can see a defect from the luxation. I'm putting an anchor, a fast tack from Arthrex into the humeral head. Glenoid is down, and I braced. I put a suture, basically bone to bone. Exactly kind of as you go on your concept, there's a tunnel down here. So I've been obviously criticized by my colleagues for this, and the idea, what they criticize, this is non-anatomical. But my approach, the concept is that I want to achieve anatomical alignment to allow the soft tissue envelope to heal in a correct physiologic position, the neuroproprioception regain until the muscle co-contraction allows dynamic stability. So in a way, very similar concept to you. For us, it's also a technical need. You will hear more from Sebastian. He will speak about cats. We just don't have the space. And Adrian was asking, would be interesting to find the right points. For me, the right points, I found them by following, obviously, joint surgery principles, stay away from critical point, safe windows, and then I place them where I can counteract the forces that cause the subluxation. So the forces, basically, I need to create some internal rotation and some adduction, but I need to be careful not over-constraining. So that's why I picked these points. So in a similar way, and that's why I love to bring up ideas, I see this more of a joint internal brace, because I'm not really bracing a specific ligament. And this is a knee multi-ligament stifle injury. You guys are the champion in this. We're going back, me, Sebastian, and Pavlos practicing. I think we already have ideas on cadavers. For us, I mean, we're really tight in the space. I use some of your guides. And what I'm doing here, I'm doing intra-articular PCL. I mean, of course, you're familiar with some of these instruments. I did a tunnel in the tibia. I use a straight microlasso. I push in a wire. Now I'm putting in a shuttling suture, some fiber wire. And then I go on and I do my femur, and then I shuttle my tape, only tape. You know, yeah, in the future when I get better, I can try to put some graft, but right now I do a tape. So then I did my meniscal repair. I combine it with an extra-articular tape, and we do a lot of fluoroscopy. We have the fortune to be able to follow them up, and this dog, kinematically, is actually looking great. And then, of course, there is the final test, which is the run, which is, of course, for you guys, is the performance. This is a whippet. I think one of you guys have it. These are amazing animals. They are muscles. They are incredible. So really, the way I see this is really joint bracing as the joint is regaining function. So the lecture came from Gordon listening to us and hearing that we have a really huge problem of contralateral injury. there is more than 50% of dogs, they are rupturing the cruciate ligament on the other side within 2 years. So obviously Gordon, visionary, says, Antonio, why don't you guys brace it as a prevention strategy? So that's a bit the discussion here, the topic. I want to show you probably how this early contralateral injury starts. The stifle, basically no DJD, really clean, the dog is minimally lame. Nobody thought there was a cruciate ligament. We do an MRI, the ligament looked pretty good, but there is, you guys are more experienced than us, some indirect signs at the insertion of the ACL, of the CCL. I go in arthroscopically, I use this in my arthroscopy courses, because I say, you guys need to learn evaluating the cruciate ligament. This looks pretty good, but then you go down at the insertion on the tibia, and the dog has a beautiful, tiny, you know, this is the black handle meniscal probe, so it's a 2 millimeter, a tiny, tiny partial tear, which it looks basically a traumatic tear. It doesn't look that there's a lot of gross degeneration. So we are investigating this. I show you, this is our research group. I have a little video clip, and currently we're studying this partial cruciate tear. It's actually Pavlos' PhD. We get the dogs, these are clinical patients, we train them for 20 minutes on the treadmill, then we collect biplane fluoroscopy images. We get CT scan, we have an engineer on the team fixed, and they do, we do, actually they do, I don't. Shape matching takes for days. And then we end up with these pretty cool videos, which are, of course make great slides for presentation. But also we get very, very accurate kinematics numbers. Rotation, translation. This is actually a dog you can see with patella luxation, patella maltracking. And so we're using this to study cruciate ligament, okay? And what I show you here are two cases. On the left, Teddy has a partial tear, but a very, very early partial tear. I call it 90-10, 90% of the ligament looks normal. And here, a more advanced, still partial, tear in iliac. The difference in MRIs is clear. Menisci in Teddy on the left looks better. Iliac has more joint disease. Then we did the fluoroscopy, but what is more interesting is the curve. So the blue curve is from Teddy, this very, very early cruciate tear with a partial tear, and you can see that it's looking great. Iliac is a partial, but the function is already gone. The kinematics is very, very difficult to regain. What is the message? The message, as in a way we were discussing with Gordon, better get there early. The best chance for us to get a normal joint kinematically with minimal risk for OA is to operate early and to maintain the function of whatever is left. To me, that was intriguing listening to you, and of course the question is the combination of a tibial slope with a ACL repair to try to maintain what is still there. Finishing with a few papers, this is a great paper from Don Holst, one of my colleagues. He did a second look arthroscopy, and you can see 3.5 years after, on the right, it's the same case, after TPLO. The ACL is looking great. So the TPLO decreases the strain on the ligament, and what is left stays there and heals. This is something else that we do in immature animal. We actually do an epiphysiodesis. We use a screw to stop the growth. You need to be 100% sure that you're well aligned in the sagittal plane, and we can treat, you can see a very early traumatic partial. This is interesting. It's in line with exactly what Kristen was telling you. Cruciate ligament strain, effective slope, decrease of 20 degrees, 27% decrease, and you can see the opposite going when you have an increase. Now, question is, as Kristen implied, okay, can we actually do something bad to the joint? So this was my very early research as a young faculty at the University of Florida. I studied the biomechanics, kinematics, and contact mechanics of changing the slope. And we actually found that there were changes. Of course, as typically happens, my colleagues said, okay, now you're telling us that we should not do TPLO. No, I'm just explaining that the TPLO makes things a lot better from a cruciate deficient, the middle one, to a TPLO treated, but the contact mechanics is not the same. So we are changing the contact mechanics, the biomechanics. I also published this one because what we see in TPLO, this might be interesting for you, when you do radical changes in the slope, we see a lot of changes in the patella tendon. We see, you can see this really tendinitis, which might be an adaptation tendon response. We see stress patella fracture. So this change in the slope is not potentially benign. And just to finish, the beautiful study from Pat Smith, from Jimmy, this of course is the big question. You know, should we forget the slope? Should we combine? I can tell you, so I guess a comment, let's not forget that these are experimental dogs. I mean, it's great results, but these are dogs that are in a highly controlled environment. These are actually clinical cases, and what they found only 45% survival. These are ACL grafts which are not braced, and as often happens, you might say that this is a failure because you have a 55% failure, but maybe 45% survival, we could push it to, who knows, 70% with the brace. So finishing the slide, what should I do? Should I brace it? Should I just go extra-articular and maybe brace an ALL? Or should I do a TPLO? Thanks very much for the opportunity.